So now we have Dr. Ravi Kumar with us. He is founder director of PRK Hospital in Chennai. So, Dr. P. Ravi Kumar, please start your presentation. It is on soft cataract management isn't easy.
Good morning, respected panelists and my dear respected colleagues. My talk is on management of soft cataract isn't easy. Why it is important now? So, as you all know, the people are coming for surgery in the early stage itself, and it has become more refractive surgery. The change of lifestyle and awareness brings the patient early for the cataract surgery, and cataract consistency very soft. So challenges in soft cataracts are, so the routine fragmentation like divide and contour, chop technique are difficult to perform. And the most of the patients are young and highly demanding. So all soft cataracts are not same. So you have to apply the different technique for different variants. So what are the management of the golden rules in the management of soft cataracts are bigger rexes, good rhino dissection, good rhino delineation, and different strategies for different variants. So these are the techniques available like carousel technique, tilt tumbling, supracapsular emulsification, chip and flip technique, double Y group technique, zero energy chop technique, and modified chop technique, and rapid technique. Let me go through one by one. So here is a carousel technique. Here I vacuum and flow rate is more than 40. The power is as less as 10. Hydro delineation, the golden ring you can see. So remove the epinucleus and debulk the nucleus. Catch hold the edge of the nucleus and wheel it out of the bag. So next one is tilt and tumbling technique. A larger axis is needed. Good hydro dissection. Hold one pole of the nucleus with the probe and tilt it and tumble out of the bag and then emulsify it. So next one is chip and flip technique. So here basic thing is reduce the overall diameter of the nucleus so that the resistance at the rexis margin is less. Low power is used, high vacuum for the holdability. Engage the anterior part and flip out of the bag. Initially we are debulking here by chipping and then flip out of the bag and emulsify it. This is supracapsular emulsification technique. Here 5 to 5.5 mm rexis is must. Hydro dissection and hydro delineation. And prolapse the nucleus out of the bag. Fill the antechamber with viscoelastic over and under the nucleus liberally. High vacuum, moderate flow rate, and low power used. And using soft chop technique, you can finish off the emulsification. This is double Y groove technique. Here, it is a modified chop and technique. The peripheral tension is widened in a Y shape to overcome the resistance by the opposite quadrant. The same thing is done on the other side also. Then engage near the peripheral epinucleus and pull one pole of the epinucleus, thereby overcome the resistance by the rexis margin. And then emulsify the cataract. This is zero energy chop technique. Here, the central groove is created using scalp mode. Held the nucleus with the adequate vacuum and chop the nucleus, divide the nucleus. There is power is not used. A high vacuum, just hold it and chop it. This is modified stop and chop technique. Here, create initial groove, the central trench. Initiate in the crack by placing the dialer on the upper surface. Drop the chopper, press downward and crush the nuclear fragment and split the nucleus. Separate the fragment and continue the chopping. This is the rapid technique. Here, rotate the nucleus freely and align the phaco tip sideways. Place the phaco tip at the nuclear rim. Impale into the nuclear rim and devour and emulsify the nucleus. So, take home message is this is a very tricky cataract. So, do perfect biometry to get the best outcome. Preoperative evaluation is a must. Proper plan about the surgical technique. Perfect size capsulorhexis. Good iodization is a must. And proper nucleus management is very important. And as usual, PCO protective measures are you should take care. Thank you, sir.
Very nice presentation.
Thank you, sir.
The thing is, for this supracapsular phaco or for prolapsing on equator out of the bag, you need a bigger rhexis.
Yes, sir.
But we know that for premium IOLs like multifocal torics, the optic of the intraocular lens should be overlapped by the anterior capsular rim. So more than 5 millimeter rhexis is not. So these techniques are not recommended for those premium IOLs.
Yes.
So you have to do some things where you can divide the nucleus in the bag with 5 millimeter rhexis for those cataracts. So we have to think for some other techniques. Yes. That is the pre-chop technique that I am going to